Hi, I'm Stephen Hodak. I'm a professor of medicine and endocrinology at NYU Langone Health in New York. I'm also the president of the North American Society for Interventional Fibrinology.
And I'm Philip James from the Doctor Thyroid podcast. I'm the host. I also host the RFAMD podcast. And today we're at the conference TNT in Italy. Dr. Hodak, welcome.
Thank you.
And today's topic is molecular profiling of thyroid nodules and how that relates to either ablation or even thyroidectomy.
Exactly right.
What a great topic. Let's dive in.
Sure.
So the topic today is molecular diagnostic of thyroid nodules.
That's right.
Why is it relevant to ablation, Dr. Hodak?
So Philip, let me tell you a story. About 10 or 15 years ago, before molecular diagnostic testing was widely available, patients that had an indeterminate nodule biopsy, meaning that when we look at it under the microscope, it doesn't look normal, but it also doesn't look like cancer, those patients almost always went to the operating room for a diagnostic surgery so that the nodule could be removed, examined under the microscope, and then we could make a definite diagnosis. But in 80% of those operated patients, what we found is that they didn't have cancer and in fact would never have cancer. Molecular diagnostic testing has been revolutionary because prior to surgery, we can now do a biopsy on a nodule, and using these very, very fancy molecular methods, we can risk stratify those nodules before a surgeon ever touches that patient. And we will know preoperatively what the risk of a cancer is. If it's sufficiently low, which is the majority of those patients, the 80% that we didn't find on operation had cancer, we can watch those patients. We don't have to operate. And in the patients that do have an identifiable molecular marker, we know the risk of malignancy, or at least a pre-malignancy, is extremely high, and those patients need surgical management.
But what you said is slightly alarming, where you said that there's an indeterminate thyroid nodule and 80% of those patients go to surgery as a diagnostic step.
100% of those patients used to go to surgery.
So they're literally taking a thyroidectomy out that may not even have cancer.
So 10 years ago, 15 years ago, yes, exactly. And we would usually pat ourselves and the patient on the back and say, good news, in 80% of cases,
and you lost your thyroid.
Or at least half your thyroid.
Oh, terrible.
But that was the best standard of practice at the time. Molecular genetics has revolutionized.
Hey, Dr. Hodak, but wait, think about that for a minute. For the poor patient that didn't have cancer, it was indeterminate,
That's
and
right.
they went ahead and removed the thyroid, the entire thyroid, just to tell them, by the way, it was benign.
So when you say it like that, it sounds like we did it in an uncaring and unnecessary way, but unfortunately, given the limits of what we could tell a patient without molecular diagnostic testing, we had no choice but to send them to surgery because that was the only way to tell them what they had. It wouldn't make sense to leave the nodule there and say, well, let's see what happens. If it spreads, then we know it's cancer. If it doesn't spread, good news, you don't have it. We removed it so we can make a diagnosis. That is now in the past, as long as molecular diagnostics can be used.
Are most doctors using molecular diagnostics?
So in the United States, I would say yes, absolutely. Most doctors are using molecular diagnostics because there are some very good commercially available tests. Outside the United States, it's still a struggle because many of the socialized medical programs have not yet agreed to pay for them. So they can be out of reach for patients. So I'm hoping to see this continue to spread worldwide. It needs to spread worldwide. Right now, the United States has the advantage of having it widely available. It's less true elsewhere.
And why have other countries not adopted it as quickly as the US?
Well, I mean, so first of all, the United States didn't adopt it so quickly either. It was a big struggle to get Medicare and third-party payers to pay like it is for anything that's new. And I think that part of it is just inertia. We've done it the same way for so long. Why should we change? And it takes a lot of convincing to make people understand. But if you think about the fact that on average, when you do one of these molecular diagnostic tests, you will get a negative result in about 60 to 70% of the cases, which means that when the testing is done 60 to 70% of the time, we can reassure the patient that you have a very low risk nodule, we can watch it, we don't have to operate, and in those other 30 or so percent, we can tell them the opposite. Gee, there's a mutation here, and depending on the mutation, we may already know this is definitely a cancer, or it is at least something that we might call a precancer, But in either case, surgical management is far more justified. So the rest of the world will catch up, but it's just a struggle to get them to understand how potent and helpful and actually cost-saving this technology is.
And draw clearly for us the connection between molecular testing and ablation.
Right. So I think these are many of the open questions in ablation are, as far as molecular testing go, are still very hot topics. The idea is if we know that we have a tumor that has a negative genetic profile, we know that's effectively the equivalent of having a benign microscope diagnosis. Those tumors we can treat. So it can be used in that way to identify the tumors at the lowest risk. The question is, if we have tumors that have a positive genetic finding, when is it safe to offer ablation to those patients? And at least conceptually, we know that those with the highest risk mutations, the answer is no, should not be done in them. They need more conventional management like surgery. But where to find that sweet spot in the middle where risk is low enough to offer ablation instead of surgery is something that's actively being studied, and I think we'll continue to learn more.
And as you share that, it just is a reminder of how personalized care is becoming.
Absolutely.
Thanks to technology, whether it's molecular testing, whether it's AI imaging, whether it's ablation.
And what's more personal than your own genes?
That's right, that's right.
Right?
Now,
Makes us who we are.
And on that topic, Dr. Hodak, before we say farewell, anything else that they should know, that we should know about molecular profiling of thyroid nodules?
Sure. I think the take-home message is it's incredibly helpful. And if you're in a country like Canada or the United States, increasingly in Europe, where you have access to this technology, it is very important that it's incorporated into the decision-making when thyroid nodules are biopsied and the consideration is, do you need surgery, do you not need surgery? In countries where it's not available, it's a very unfortunate but real fact, and it's still a real sore point. If it's available to you, make sure your doctors are using it because it really is a game changer.
If somebody listening or watching wants to get in touch with you, how should they do so?
Well, they can find me at NYU Langone Medical Center in New York, and I think that's probably the best way to get in touch with me.
Everyone, farewell from Italy. Thanks for watching.